Good afternoon, Dr. Krishnan. Thank you so much for the kind invite and also for including our residents and our students at this wonderful seminar to let them expose of what the wonderful things that can be done. And Prakash is just a wonderful resource for us at the Podiatry College for helping care for our patients, not only at the Podiatry College, but for the foot and ankle service we run at Metropolitan Harlem and Lincoln Hospitals as well. So I have no disclosures relative to this talk. And a number of years ago, I was trying to improve my golf. It didn't help. But I read this book by a famous golf coach, and what hit me important was the quote that when asked to teach someone how to get out of a sand trap, first I need to teach you not to get into one. And that's really key, I think, with amputation. What we're looking to avoid is end-stage feat like this, which frequently will start out as a neurotrophic or perhaps a neuroischemic ulcer in the forefoot under a toe that ends up going to downhill to a TMA. The TMA breaks down and ultimately to a BKA or higher. So this is what we're looking to prevent. Hopefully these days are the past. I showed our residents one time this picture. I said, name all these people here, and it was interesting what they came up with. But that's another time, another place. So again, these are the type of things that are indeed preventable. Some of the things are a tragedy. This is sad to say, colleague of mine on a 27-year-old female who came in for a bunionectomy, ignored the fact that she had scleroderma, and this was the result of her. And this was another patient that was sent to us who had another place, an ingrown toenail, in someone who had a PAD, obviously wasn't worked up. So these are all the things that can be preventable. I think we know we're doing pretty good in terms of decreasing the amputation rate in ischemic muscle because of the great work you people are doing. It's kind of flatline in the neurologic, the neuropathic foot type. We're not doing quite as good as that. Maybe you don't see these patients quite as much to do interventions because their problem is primarily neuropathic, which is ignored. This graph is well known, I think, around of what the effect of a DFU in terms of not that this is the causation, but in terms of DFUs and critical limb ischemia, the mortality in these patients is quite severe. So we like to say, and this is a slowing of the World Congress on Diabetic Foot, if you ignore your feet, they will go away. The causal pathways for ulceration are pretty well defined and been articulated in study after study. Neuropathy is the most important component cause. The clinical triad of neuropathy, a deformity, and some trauma, when put in conjunction with ischemia is the stepwise approach to what happens to amputation. About 80% of ulcers are ultimately preventable. Wound care teams, there's lots of work that the interdisciplinary approach to wound care is the way to go, not only in terms of outcomes, but in terms of cost. I would urge all of the fellows here who are about to go into practice, align yourself with a podiatric practice or a podiatric group. Nobody sees more sick feet than podiatrists. We see diabetic feet, ischemic feet. We need a good referral mechanism to refer these patients to. So I think going into practice, the first thing you want to do is find yourself a good podiatric group that can be as a great referral mechanism. In terms of what we do, we're obviously going to make sure that the patient's comorbidities are being appropriately handled by their internist, by their endocrinologist, nutritionists, that they're optimized medically as much as possible. We screen for PAD. We do all the things that you do in terms of screening: pulses, capillary fill time, Doppler pressures. And when we find a PAD, we're looking for a good interventionalist to send these patients to do something prophylactically to prevent wounds or ischemic wounds, and when the wound occurs, to do something to help us cure the wound. We work, when we have a wound, it's important that we work with our ID colleagues to control infection. We tend to follow the ISDA classifications for management of infections. I mean, that's a critical component of it. And neuropathy is another critical component of dealing with the diabetic or the neuropathic foot. Neuropathy, most of the time, is thought of as the painful neuropathy. Pick up any newspaper, all the gabapentins and Lyricas and Cymbaltas from medical management of this, but it's really the sensory neuropathy or the lack of sensation that leads to the formation of the ulcers. Don't forget autonomic neuropathy. The result of that is usually dry scaling skin that can serve as a crack, as a fissure, portal of entry for it. We screen for neuropathy in all these patients. The screening of that is usually quite simple. This isn't the autonomic neuropathy. This isn't just xeroderma or dry skin. This is a direct result of autosympathectomies that are occurring in the patient. This needs to be managed with appropriate moisturizing creams and patient evaluation. Deformities, this is really the crux of where it goes. These corns, these calluses are the result of pressure, and we need to identify the pressure areas, and we will routinely do pressure analysis. In the old days, it was just step on a pressure mat. Now we're doing computerized gait analysis to identify the areas of increased pressure and offload those prophylactically. We can look at not only the height of pressure, but what's as important is the length of pressure. So it's the area under the curve, not just the peak pressure, but for how long a specific area is loading. In terms of wounds, once they occur, we need to jump on them right away. We want to prevent the progression from, if you want to use the Wagner classification of no ulcer up to gangrene of the entire foot. Not all wounds that we see are automatically ischemic or automatically neuropathic. There are other causes of wounds on the foot, and we will evaluate this term, the etiology of it. And again, you've seen all of these. The principles of good wound care, obviously, comorbidities are managed. Detect and manage vascular disease, manage infection. We like to differentiate a more neuropathic ulcer from an ischemic ulcer. They can appear similar, but you can see the good granulation tissue. And this foot's relatively well perfused. You can see the good circulation around it as compared to a foot that looks like this. What we're looking to do is prevent that acute wound from getting into a chronic wound, and the basic good wound care that initially is followed is debride, offloading, therapeutic agents, and surgery. We'd like to say it's not what you put on a wound, it's what you take off the wound, and that starts with the bioburden. Debridements, enzymatic, hydrotherapy, surgical debridement, curettage, whatever it takes to get rid of that bioburden, removing the necrotic tissue or the hyperkeratotic tissue around there is critical. Most of this stuff can be done clinic-wide or bedside. In more advanced cases, go into the surgery using debriding agents. Surgical debridements is important, enzymatic as well. There are a whole host of wound dressings that are available to us, and we try to tie it in to the type of the exudate that's going there. So a low exudate, we'd want to use a film. There's a heavy exudate, a specialty avoidment. Negative pressure therapy has become more the standard, I think, as more than considered an advanced wound care on it. So we tend to use a lot of negative pressure therapy on the wounds. This is a big market out there for wound products on it. There's lots of different biologics that are available. These, one thing about them all is they're really expensive, and hence cut to the OIG report. This is on the radar scope for the OIG and on these interventions, so we need to be careful about it. Not only do we take off bioburden and tissue, but pressure. And then we have our tricks that we use of offloading the ulcers in various modalities, total contact casting, an instant total contact cast where we put a cam on and then put a dressing around it so that the patient cannot remove it. Total contact casting just offloads the area tremendously. It's a little bit labor intensive. Sometimes surgical offloading underneath here by doing an arthroplasty procedure to offload that. We tend, for forefoot ulcers, to do a simple percutaneous tendo-Achilles lengthening that works wonders in offloading the forefoot. In more advanced cases where you start getting Charcot breakdown, where you're doing beaming of the forefoot, advanced Charcot, external fixators to reconstruct the foot, and then the reconstructive ladder. As a rule of thumb, we know that it's been shown that if a wound with good wound care closes by 50% within about 4 to 5 weeks, that's a good prognosticator that it's going to go on. If at that point you have to stop, reevaluate, recheck all the things, and that's where you start to consider advanced wound technologies. So that was very brief, show you what we do. We can't do what we do without the help of our vascular colleagues, and we thank you for helping us take care of our patients. Thank you again for the invitation.